Okay, we're going to go ahead and finish up with inner ear disorders. The first inner ear disorder that I wanted to talk about was sudden sensorineural hearing loss, and this is just sensorineural hearing loss that occurs very rapidly. It presents itself with various symptoms. It could be unilateral or bilateral. Usually upon awakening, people will notice that they can't hear out of one ear or the other or both, accompanied by oral fullness, tinnitus, vertigo. The tympanogram obviously would be normal because this is a sensory issue in the cochlea. And then the treatment is to provide steroids, corticosteroids, and the sooner the better, usually within the first 24 to 48 hours, is the best chance for recovery. Autoimmune ear disorders, basically this is when just the immune system attacks itself and attacks the body, and it occurs, and some of the symptoms are progressive hearing loss. It could be stable, it could fluctuate. It's very, very unpredictable. Vestibular systems are common as well, so not only do they have hearing issues, they have balance issues. And then the treatment also is high-dose corticosteroids or immunosuppressive medication. Meniere's disease is another one. Some of you probably know somebody that has it. It's not super prevalent, but when somebody has it, it's very debilitating most often. And so the disease is characterized by severe nausea, severe vertigo, usually nausea and vomiting when they're in an active, having an active attack. They have a tinnitus that's usually described as a low-frequency roaring or buzzing, not really a high-pitch tinnitus. They have a low-frequency sensorineural hearing loss. You can see it circled over there that rises. They have fullness in the ears. And, of course, it would have a sensorineural hearing loss, as you can see, with a normal tympanogram, obviously, because, again, the external ear is not affected. Again, here are the symptoms: low-frequency roaring tinnitus. And, again, it can present with typically low-frequency hearing loss that then eventually becomes more flat. And one of the things about Meniere's disease is hearing will fluctuate. They'll have good days and bad days. It's caused by a retention of endolymph in the cochlea. Sometimes you'll hear it referred to as endolymphatic hydrops, but there's too much endolymph in the cochlea and it's not being recycled appropriately. Okay, so that's the cause of it. Excessive endolymph. Here are some other diseases that can cause hearing loss. Again, I mentioned measles and mumps are a little more common than they have been in the past because of a lack of vaccines. Bacterial meningitis can cause substantial hearing impairment. And then on the right you have some others that are very, very rare but can occur. Ototoxic drugs, so medications that cause a negative ototoxic effect. Some of the very strong antibiotics, streptomycin, neomycin, kanamycin, gentamicin, are very strong antibiotics that can cause hearing loss and vestibular system issues. Aspirin, high-dose aspirin, not the baby aspirin that a lot of people take who've had blood, need it for blood thinning purposes, but like high-dose aspirin. Chemotherapy agents like cisplatin, loop diuretics for diuretics to remove water from your body. Furosemide is one of the most common loop diuretics. Okay, so those are ototoxic medication. Noise-induced hearing loss, I always say this is the one that is absolutely preventable, and often is not. And so it is a permanent sensorineural hearing loss that occurs due to chronic exposure to high-intensity noise. It could be recreational noise, like firearms, loud music, concerts, things like that, or occupational noise. when you have noise-induced hearing loss, it's always sensory neural, and you can't see the sensory neural. They don't have bone conduction scores, but this is meant to show you this noise notch. Oops, I moved it. This noise notch, which occurs somewhere between 3,000 and 6,000 hertz. So somewhere in this region, and it doesn't always have to be 4,000 hertz, but somewhere in this region you have this notch, and then you have this recovery over here at like 6,000 and 8,000 hertz. They call that a noise notch. It occurs in that region because of the physiology, the anatomy and physiology of the ear, and that ear is just very sensitive. It's where it occurs in the cochlea that it makes it so sensitive. Oops, sorry. And so this is noise-induced hearing loss. It's sensory neural, has the noise notch, which is usually somewhere around 3,000 to 6,000 hertz. Presbycusis is just hearing loss due to aging. Typically has a sloping configuration. It's very gradual. You see more hearing loss in the high frequencies than you do the low frequencies, it's usually for people that are, it can present itself at any time. There's people in their 50s that have this kind of loss, but usually it's people that are in their 60s and later. Now, I think the last one that I wanted to cover was an acoustic neuroma. So essentially, acoustic neuroma is technically called a vestibular schwannoma, which arises from the support cells, the Schwann cells in the vestibular portion of the 8th cranial nerve. And so the audiometric results obviously result in a sensory neural hearing loss because it's on the nerve, right? It's on the vestibular nerve, and has reduced word recognition scores. Okay, and so people, if you see here, the left ear is normal, the right ear is starting to have this sensory neural hearing loss. Even though the hearing loss is not super severe, they'll start to lose their word recognition abilities. Typically have unilateral tinnitus in the ear that's affected. Most likely they'll have some vestibular systems. The acoustic neuroma is a benign tumor. It's slow growing, but it can eventually start to fill up all the space in the internal auditory canal and cause some substantial problems. Okay, but again, it's technically termed a vestibular schwannoma because it arises from the vestibular portion of the 8th cranial nerve, which right close to where the auditory portion joins. Okay, and of course the tympanogram would be normal because it's a sensory loss. Here you can see a visual of a large acoustic neuroma in the internal auditory canal. Now, one thing I always go over quickly is, and we talk about the auditory brainstem response, the ABR test, which is this over here. The way the ABR works is we present very brief sounds, either clicks or little tones that are very brief, to the auditory system. The auditory system will then respond, and we will see these 5 peaks. If the hearing is normal, we'll see these 5 peaks, Roman numerals 1 through 5. And we look at certain points, like we look at what we call latency, like where does wave 1 occur? It's like 1 point something milliseconds. Where does wave 3 occur? It's 4 point something milliseconds. Where does wave 5 occur? So we look at where these waves occur in terms of their latency. And what you find is if this is the left ear audiogram, this is the left ear ABR. And so there's all these values that we use. We look at 1 through 5, 1 through 3, 3 to 5. We look at all these values, but suffice it to say that you can see that 1 2, 3, 4, and 5. So 1 through 5 occurs in about 3.72 milliseconds. So the time from here to here is 3.72 milliseconds. What you notice in the right ear is that 1 to 5, it takes about 4.6 milliseconds. So this is indicative of some slowdown of the neural response coming from the right ear. So this is one of the ways that we diagnose, help the doctors diagnose an acoustic neuroma. And I figured I'd show it to you because you all have probably heard of the auditory brainstem response. This is an actual recording from an auditory brainstem response from somebody with an acoustic neuroma. And again, they use this. This is a similar finding to what you would see with auditory neuropathy or auditory dysynchrony. Okay, this is a very similar outcome. Okay, because if you remember, in auditory neuropathy, which is next, you have poor neural synchrony. And so with auditory neuropathy, the problem is somewhere between the outer hair cells and the auditory nerve, most likely somewhere in the inner hair cell connection with the auditory nerve. And I want you to do that reading because it's a very good reading that talks about it. But typically you'll see hearing loss that's so variable from severe to profound to normal. I mean, it's very variable. Typically poorer than expected word recognition. So you might have somebody with a mild hearing loss that has like 5, 10, 15, 20%, 30% understanding, and you just would not expect that. The tympanogram would obviously be normal because it's a sensory neural issue. The acoustic reflex would be absent or elevated. And in OAEs, one of the hallmarks is that you have present OAEs. In auditory neuropathy, one of the hallmarks is you have normal OAEs, but you have a poorly formed or absent ABR. Okay? So here are some of the risk factors from the article: low APGAR scores, low birth rate, hyperbilirubinemia, premature birth, mechanical ventilation, and a stay in the NICU. So any child that's in the NICU should undergo an ABR test because the ABR test will catch auditory neuropathy. The OAEs will not catch auditory neuropathy because if you remember, otoacoustic emissions test cochlear function. In auditory neuropathy, cochlear function is normal. So if they only do an OAE at a newborn hearing screening, they're going to miss auditory neuropathy. Now, auditory neuropathy is not so present that you should do ABRs on every newborn, but if they have any of these risk factors, you should do an OAE and an ABR. Okay? As far as treatment, amplification is one treatment, but remember, this is a neural problem. You can make things louder. It's like having a busted speaker. You can keep turning the volume up on a busted speaker and it never sounds better, right? All of you have probably been in an older car that had that or have heard what a busted speaker sounds like. So amplification doesn't always work. What lots of these kids need is cochlear implantation to provide a strong, synchronous electrical signal to the cochlea, so that way they get a clear, more crisp signal versus taking a basically busted system, taking a system with physiologic damage and making it louder. So in often cases, amplification doesn't work as well. Some it does. So you always try that first. You always try amplification before cochlear implantation is considered. But in the end, most kids with more moderate to severe auditory neuropathy need cochlear implantation. So that's it for auditory disorders.